and happy July. Though this painting of the San Francisco Golden Gate might tell you otherwise, I am in Connecticut for the next 2 months doing my remaining mandatory rotations. This month I was in the intensive care unit, and next month I will be in the emergency department. This month's video is going to be a little bit different. Rather than recounting the events of the previous month, I want to talk about a specific topic that I've been thinking over for the last couple of weeks. Throughout medical school, I've heard about this concept called the hidden curriculum, which I never really learned how it was defined, so I actually had to look it up for this video to see how people have defined it in the past. My understanding is that the hidden curriculum consists of things that you learn that aren't explicitly taught to you. This can include things like the culture of the place where you're working or the norms and values of that place. And you kind of pick up on these things rather than someone telling you explicitly. This video is kind of about the hidden curriculum. It's mainly about some of the things that can make the transition from preclinical to clinical a little easier. The first concept I want to talk about is something that I only became aware of a couple of weeks ago when a preceptor actually pointed it out to me. In the transition from the preclinical to the clinical years of med school, you learn to flip the script, so to speak. During your preclinical years, before you set foot on the wards, you learn how to gather and analyze information in a very systematic way. You start out with the history, then you go to the physical exam, then after that to the assessment, and finally to the plan. Starting with your first clinical rotation of med school, you learn to approach patients in a very different way. Let's say a patient comes in with chest pain. Immediately, diagnoses start running through your head. At the same time, before you even walk into the room, you're already thinking about the kinds of things that you might need to do for that patient. You're also thinking about the physical exam that you might want to do on that patient. So, before even walking into the room to see the patient, you already have a working assessment, a differential diagnosis, and potential plans running through your head. Then, when you're actually talking to the patient, as you're gathering the history, you start crossing things off in your head, moving things up your list, and narrowing your differential diagnosis. Some of the difficulty that comes with the preclinical to clinical transition is learning how to flip the script like this. Rather than starting with the history, then moving to the physical, then the assessment, you kind of start with the assessment and almost work backwards. You still write your notes following the SOAP format, subjective, objective, assessment, and plan, but you're almost thinking in reverse. The second thing I want to talk about is the temptation to cut corners. This can range from writing things on your physical exam that you didn't actually do, to not going very much into detail about their family history, or not asking some things in the social history because it doesn't seem as important, etc. You'll see a lot of residents and attendings do this, and you might be tempted to do it yourself. But someday, maybe multiple times, you'll be asked about those things that you didn't ask about, and there will be a time when it actually matters. This is why we are at first taught to do everything, even when the diagnosis seems really simple or straightforward. As medical students, we haven't yet developed the clinical experience that comes from learning to tie seemingly unrelated things together. However, we have to watch out for the dangers of relying on pattern recognition too much, because this can cause us to miss things. So even as you're gaining clinical experience, remember to keep your differential broad and always be looking out for other conditions that you might be missing. Number 3, presentations, both written notes and oral presentations, are key. Get good at them. As a medical student, presentations are often the only time that an attending can work with you and see how you think. Your oral presentation is basically a persuasive argument. You're telling a story about your patient's presentation to try and convince whoever's listening to you that your diagnosis is correct and that the other diagnoses that could be considered are less likely. There are many places where the hierarchy and formality of medicine can seem kind of ridiculous, but I think presentations is one place where formatting actually really does matter. By following that standard format, it makes it much easier for people who are listening to you to understand what you're trying to get across. This is why attendings can get annoyed if you put things out of order. I will say that unfortunately every attending has slightly different preferences for how they like their presentations done. The attending will correct you, they'll let you know how they prefer their presentations to be, and you can just move on. Don't take it personally. A little related note, don't step on other people's toes. I feel like this should be self-evident, but it always is worth mentioning. If another student or resident is presenting and they get something wrong, don't step in to correct them. If the attending asks a specific person a question, Don't jump in and answer it for them. It's just gonna make you look bad. Number 4, everyone you work with will be an example of what to do and what not to do. I think this is what a lot of people talk about when they talk about the hidden curriculum. You'll see everything from really annoying hierarchical stuff to politics between different providers or even different departments. You'll see people who behave in ways that you would never want to emulate, and you'll see people who you really admire, who care for patients in a way that you want to do as well, who treat other staff with respect, and who generally can serve as role models to you. Your clinical years of med school are the best time to take all of this in, to learn what kind of doctor you want to be, to learn about the different styles of different providers, and figure out what might work best for you. Do remember though, if you don't like what you see, don't be the one to perpetuate it. Number 5, probably the biggest point that I wanted to make in this video. Communication between providers is critical and really not emphasized enough during medical school. Most of medical school rightfully focuses on the relationship between the doctor and patient, but I think communication between doctors can suffer a little bit as a result of that. So here's Florence's quick and dirty guide to some of the inter-provider communication you might have to do even as a medical student. Before you call a consult, there are a few pieces of information that you have to have at the ready. First, obviously, is the name of the patient. Maybe their date of birth or medical record number to help the consultant look that patient up when they're on the computer. Secondly is your clinical question. Why are you calling this consult? You can't just call someone so they can follow along with the patient. You need to have a good reason why you want that person to be on the patient's care team. Third is any information about the patient that is pertinent to what the consultant needs. Let's say you're calling a nephrology consult. It's probably important for them to know that the patient has type 2 diabetes that has been very difficult to control and that they have a lot of protein in their urine. Similarly, if you know certain specialties will get certain types of labs, try to get those labs ahead of time to make the specialist's job easier. If you're consulting a nephrologist for acute kidney injury, they will probably want to know about urine electrolytes, urine sodium, urine creatinine, things like that. So just get those ahead of time so that the nephrologist doesn't have to call you back and say, hey, I don't have any of these results. I need them before I can make any decisions about the patient. When you actually call a consult, be respectful and mindful of your consultant's time. Start out with a concise one-liner. Patient's name, age, sex, history that is pertinent to the consultant, and the reason why they were admitted to the hospital. And then follow it up with what your clinical question is first before you dive into more of the pertinent history. This allows the consultant to frame the information that you're giving them in terms of the clinical question that you're asking. Hopefully that gives you a little framework on how to talk to consultants. The other main time when we as medical students may be communicating with different providers is during transfers of care. This can be everything from hospital courses to discharge summaries to sign-off notes if you're on a specialty service. With all of these notes, the main goal is to demonstrate to another provider why that patient no longer needs your particular care. In the case of a hospital course note, it might be the ICU communicating to the floor why this patient no longer needs ICU level care. In the case of a discharge summary, it might be a hospitalist letting a patient's primary care provider know what happened during the patient's hospital stay and what things the primary care provider might need to follow up on. In the case of a sign-off note, it might be the specialist letting the primary team know how the patient has improved in such a way that the specialist no longer needs to be part of their care team. As a medical student, you may be asked to help write some of these notes. The main goal is to keep in mind who you're talking to and what information they might need. Most providers will probably not need an exhaustive day-by-day account of the patient's hospital stay. Rather, you should let them know what's been done so far, what's resolved, and what that provider might still need to follow up on. I can tell this video is going to be a longer one than usual, but I hope it was helpful. As you transition from preclinical to clinical years, or even as you progress through your clinical training, I hope I was able to make some of these hidden concepts a little less confusing and a little more clear. That's all for this one's video. See you in the next one!